Okay, well, thank you everyone for coming today. My name is Casey Phillips, and I'm the lead pharmacist with the Antimicrobial Stewardship Program in Regina. So just for everyone out there in telehealth and webinar, or checking in via webinar, if you could just make sure to mute your mics in front of you so that we don't have a lot of background noise. And you know, I've had the pleasure of working with Joel and Victoria for the last 6 weeks here, and they've joined us from University of Manitoba in our SPEP program, and we've had a number of different experiences. They've been able to join us up in Saskatoon at our symposium. We've done a lot of clinical work, but we've also been focusing a lot on the teaching and education components that are necessary for stewardship. And with most antimicrobial stewardship programs, or really all of them that I know of, they're very focused on the inpatient side of things, and we've been trying to branch out into the community, working with our family physicians, and also looking at how do we do a better job of engaging with community pharmacy in the central role that they can play in antimicrobial stewardship. So welcome to everyone who's joining us today on site, and people at other sites as well. We have people tuning in from across Saskatchewan, across Manitoba, and Ontario as well. So with that, I'm going to hand it over to these guys. They put together a great presentation for us today, and we welcome any comments or questions at the end. So thanks, and take it away, guys.
Awesome. Hi there, thanks for having us. My name is Victoria Chung, and this is Joel Denowith, and we are fourth-year pharmacy students from the University of Manitoba. We've been working with the Antimicrobial Stewardship Program for the past 6 weeks as part of our hospital rotation. We're here today to discuss antimicrobial stewardship in the community setting, specifically in relation to community pharmacists' role, as well as the opportunities and challenges that are present in terms of improving antimicrobial use and the quality of care that our patients receive. To get a bit of background information on this topic, we reviewed literature that pertains to antimicrobial stewardship initiatives in the community and outpatient setting, and we also interviewed several community pharmacists around Regina with varying clinical backgrounds to determine what they knew of antimicrobial stewardship and what opportunities and challenges were present in their individual practices.
So before we get into what role pharmacists have in antimicrobial stewardship, it's important we have a good understanding of what exactly antimicrobial stewardship is. Several definitions exist, but ultimately it relates to the optimization of antimicrobial use. The goals of the antimicrobial stewardship program we have here gives you a good idea of what's involved in optimizing their use. Primarily, we have the first point, supporting healthcare professionals in choosing the right drug, dose, duration, and route when treating antimicrobial-related illness. The second, maybe less intuitive point, includes promoting a collaborative effort among healthcare professionals to support each other in achieving the best possible patient outcomes with respect to antimicrobial use.
So why is it important? When we know that the end goal is to have the best possible patient outcomes with respect to antimicrobial use, but it's becoming increasingly difficult with the rapid emergence of antimicrobial resistance, which has a tremendous impact on clinical outcomes. It also happens to be a global concern that is one of the biggest health threats to global health, food security, and development today, according to the WHO. So resistance occurs when microorganisms change when exposed to antimicrobial agents in a way that reduces the effectiveness of medications. And this process is accelerated when antimicrobials are overused and misused. As a result, infections tend to persist, leading to poorer patient outcomes, including increased morbidity and mortality. So are there any drugs in the pipeline, and can we expect any new antibiotic agents or classes to come to market? That's another issue that comes up when we talk about running out of viable agents in light of resistance. And technically speaking, yes, there are, but new antibiotics in research and development has been scarce and limited, with only one potentially novel class discovered as recently as 2015 since the 1990s. As well, it typically takes upwards of 10 years and approximately $10 million to bring a drug to market, which boils down to the fact that we need to preserve our current agents for as long as possible.
So as Victoria was saying, and I'm sure most of you are all aware, antimicrobial resistance is a real issue that's affecting us right now. I have a couple of graphics here to show you that. The first diagram on the left shows the dates of introductions of antibiotics to market and the year at which resistance is first seen. You can see that all antibiotics will inevitably have resistance develop towards them. In the case of levofloxacin, you can see that resistance was even seen in the same year it was introduced. Going back to the point Victoria made, you can see that antibiotics will have a limited lifespan of usefulness. The next graphic on the right shows you the prevalence of drug-resistant bacteria are on the rise. This is American data we have here, but you can infer that a similar scenario is playing out here as well. These organisms, MRSA, VRE, and FQRP, are causing issues in Canadian hospitals and communities. One Canadian statistic we do have is that there has been a 7-fold increase in the incidence of vancomycin-resistant enterococci infections between 2007 and 2012. Also, deaths related to Clostridium difficile alone have increased 5-fold in the past decade. This is a multifaceted issue that needs to be dealt with through various different approaches.
So why are we talking about the community role right now? Considering that community pharmacists are oftentimes the very first point of contact when patients have questions regarding medications and illnesses, as well as the last healthcare provider that the patient will be in contact with prior to dispensing and administration of their medication, this is a huge opportunity for intervention. As Casey said, antimicrobial stewardships programs are typically focused in the hospital setting with limited interventions and outreach to the community. But considering that more than 60% of antibiotic expenditure is associated with the outpatient setting, which includes prescriptions from walk-in clinics, family physicians, and from the emergency department, it's important that we expand stewardship into this healthcare setting as the majority of outpatient prescriptions are received by community pharmacists. It's also important to keep in mind that expenditures in antibiotic use are not equivalent and that IV agents that are predominantly used in the inpatient setting are much more expensive than oral agents. So we can anticipate that the actual proportion between the outpatient and inpatient use of antibiotics is much higher, with some references reporting up to 70%. So are all antibiotics prescribed appropriate? On the left is a graphic from the CDC that represents the use of antibiotics in doctors' offices and emergency departments in the U.S. As you can see, at least 30% of the prescriptions are deemed to be unnecessary prescriptions, so likely for viral illnesses. And while the other 70% are necessary prescriptions that can still be improved in terms of agent selection, the dose, and the duration. The 30% is considered to be a conservative estimate, and it's likely that up to 30 to 50% of antibiotic use in the community setting is considered inappropriate. So obviously, again, there's an opportunity to intervene.
So this question, does the patient need antimicrobials, is a question all healthcare professionals should be asking when interacting with a patient. Although it is important and necessary that prescribers ensure antimicrobial use is warranted, all healthcare professionals interacting with a patient can play a role in ensuring antimicrobial use is optimized. Stewardship can be broken into 4 different segments that Victoria and I will get into in a bit, but this question works its way through all 4 segments. Regardless of where you are in the process of treating a patient, you can and should ask yourself this, because we know that using antibiotics when use isn't warranted is a major contributor to increased resistance.
So what can we do as outpatient healthcare providers? Recently, there was an article that was published by Dobson and colleagues that outlined outpatient antimicrobial stewardship, as this is an area that we know should be expanded into, given the data that we have outlining misuse of antibiotics in this setting. The article provides a framework for outpatient stewardship initiatives with interventions that are designed to affect processes that are along the patient infection continuum, which describes the point at which patients interact with healthcare providers when they do have infections, whether viral or bacterial. This continuum is broken down into 4 patient care segments, which include the need to seek care, the decision to prescribe and agent selection, dispensing of the antibiotic, and post-encounter care. Community pharmacists, along with all other health care providers in the outpatient setting, including general practitioners and nurse practitioners, are involved in all 4 of these domains. And within each patient care segment, there are opportunities for action, which we will be discussing in the coming slides. Pharmacists in the community already embrace many of these opportunities in their daily practices without identifying that they are necessarily stewardship practices, but there's also a lot of room for improvement.
So the first segment we have is need to seek care. Many of the opportunities for stewardship in this area relate to preventative interventions, that is, ensuring that antimicrobials don't need to be used in the first place. It can be easy for community pharmacists to get involved with these sorts of activities, and we can see that happening in practice right now. Of the pharmacists we spoke with, all provided immunization services, and one mentioned that it was an essential service for a pharmacist to provide. He went on to say that we shouldn't consider hiring a pharmacist who wasn't trained to provide these services. Immunization isn't the only opportunity to prevent antimicrobial use, though. General education opportunities that can prevent antimicrobial use present in a community pharmacy fairly consistently, and not only when prescriptions for antimicrobials are being filled. Education regarding viral versus bacterial infections, proper sneezing etiquette, and promoting safe sex practices are just a few examples of how a community pharmacist can get involved in preventing antimicrobial use. One great resource for patients if they have questions or are just curious about antibiotics, bacteria, or antimicrobial stewardship is the Antimicrobial Stewardship Program page on the Health Authority website. It has patient-friendly videos and graphics, and the link is included on the bottom of the slide here.
So the second patient care segment is the decision to prescribe antibiotics and agent selection. The main focus of the segment is improving antibiotic selection, which includes determining if antimicrobial use is warranted to begin with. Remember our big question, does this patient need antimicrobials? And if so, what the most appropriate agent or management strategy is. Most of the opportunities for action in this segment are aimed at prescribers, including prescriber audit and feedback, where antimicrobial prescribing is reviewed with practitioners. Use of point-of-care diagnostic tests in clinic, prescriber education and behavioral intervention, including regular practice updates, the development of practice guidelines, use of prescribing tools that may suggest therapeutic alternatives or require accountable justification for therapeutic choices. An example of a prescribing tool that may aid in practice is the viral prescription pad that was created by the Antimicrobial Stewardship Program that gives patients a non-pharmacological or over-the-counter management strategy for their viral illnesses, mitigating the use of antibiotics. Other opportunities for action include utilizing antibiograms to help direct prescribing and either developing allergy assessments and penicillin skin testing programs or referring to allergists when appropriate. It's a great chance for patient education at this point, either by prescribers or pharmacists when adverse effects of antimicrobials are reported as allergies, such as nausea, diarrhea, or stomach upset, which we know are not true allergies. At this stage, there are fewer opportunities for community pharmacists to be involved, but with the development of prescribing for minor ailments, which has allowed pharmacists in Saskatchewan to prescribe for illnesses such as acute uncomplicated UTIs, along with the expanded roles that are currently being taken on by pharmacists, it's something that we'll be seeing changing in the future, in which case utilizing antibiograms and point-of-care diagnostic tools at the pharmacy level would be more commonplace.
Getting into penicillin allergy and agent selection, there was a study published mid-November that really exemplifies the importance of proper documentation and questioning of allergies. It looked at patients in Wisconsin who were receiving antibiotics in hospital for greater than 24 hours. This facility was already good at documentation of allergy in the patient's chart. It was done in 90% of patients observed. The intervention that took place was further investigation and questioning of the allergy. If a beta-lactam allergy was noted in a chart, a member of the pharmacy team searched the patient's electronic medication record to see if they had a previous tolerance to a beta-lactam. If so, that information was added to the patient's chart. The results of this study found that this additional information added to the chart resulted in an increased use of beta-lactams. Change to beta-lactam antibiotics during patients' stay in hospital went from 12% to 26%. And discharge beta-lactam prescriptions went from 18 to 42%. It is also important to note that the author states that the most common non-beta-lactams seen in this population were fluoroquinolones and vancomycin. Obviously, if we can minimize the use of these agents in favor of more narrow, better tolerated agents, this would lead to better patient outcomes. The result of this study also reinforces the importance of community pharmacists and education opportunities. Community pharmacists should frequently reassess documented allergies entered in patient profiles to ensure they are true and the type of reaction is noted, as this can affect future prescribing. Educating patients on types of reactions and cross-sensitivities can also have an effect on prescribers, as the information communicated to them from patients will be more reliable.
So the third and most intuitive segment for pharmacists to be involved with is dispensing of the antibiotic. This is the aspect that all community pharmacists are familiar with, whether they are aware of the principles of antimicrobial stewardship or not. Educating patients is the primary focus and entails providing patients with information regarding their medication, which includes the dose, duration of treatment, common side effects to expect, and time expected for response and resolution of their symptoms. It also includes other pertinent information such as proper storage conditions, administration, so taking with or without food, and spacing from certain foods or other medications, and what to do if doses are missed, which all lead to better patient outcomes. With antibiotics and all other medications, it's important that all of the above points are discussed with each patient. And are we doing a good job here? It's important to reflect and see if we're consistently communicating all of the vital information each and every time. Keep in mind that while it may be the 10th time you've repeated yourself in a day on something simple like amoxicillin, it may be the very first time that the patient has heard this info. In these cases, counseling checks can be extremely helpful. And other issues contribute to whether or not pharmacists are able to give their patients proper in-depth counseling, which leads us into some of the limitations and barriers that may be present in a community pharmacist practice.
The last section of stewardship includes post-encounter care. This has to do with care provided after an initial recommendation was made and acted upon. Primarily, this has to do with follow-up. That is, a healthcare provider, such as a community pharmacist, ensuring the best action was made regarding antimicrobial selection. It can take place even if the initial decision was to not use an antimicrobial. This could be the case in the setting of a middle ear infection in a younger child, where the recommendation is the watch and wait technique. That is, waiting 48 to 72 hours for an infection to resolve on its own, as these types of infections are most commonly viral. Communication at the 48-hour mark ensures the correct course of action will be taken, either continuing with symptom management or initiation of antibiotics. This also builds trust between patient and care provider. Education opportunities can also present at this time, relaying any information that may have been omitted from the initial education provided upon dispensing. Follow-up with education may prevent the patient from seeking further unnecessary antibiotics. Examples of such may include educating a patient that a dry cough may persist beyond eradication of the bacteria in the case of a pneumonia, or that azithromycin continues to have a therapeutic effect beyond the administration of the last dose.
So now that we've talked about the opportunities for action within the 4 patient care segments, there are some limitations and potential barriers that we should go through that are present that may hinder a community pharmacist's ability to provide the best possible patient care, as well as their ability to be better antimicrobial stewards. So to determine what those barriers may be in a community practice, we conducted surveys at 5 community pharmacies throughout Regina. These surveys consisted of open-ended questions that queried the pharmacist's baseline knowledge of what antimicrobial stewardship was, whether stewardship activities were being conducted currently in their practices, tools and resources that may be lacking, and what may impede the implementation of those activities. We found that variations between the pharmacies exist based on proximity to healthcare centers, such as the Regina General Hospital, Pasqua Hospital, and other walk-in medical clinics, and the existing infrastructures of each work environment. These variations yielded both common and differing obstacles and can present a challenge when implementing stewardship practices at this level. And it's important to determine what specific barriers exist in each practice in order to determine the best individual solution for that pharmacy. So before we delve into the issues that came up throughout the interviews, I should mention that the challenges that community pharmacists face are oftentimes multifaceted, and many of the issues tend to overlap and intertwine. So the following is what we found to be the case for pharmacists within this community, and they are likely applicable province-wide, both in Saskatchewan and Manitoba. So a common issue across the board is that pharmacists may only have access to a small piece of the clinical picture. Some of the key information that is lacking on prescriptions written for antibiotics include an indication, patient weight on prescriptions for children, and at times the duration of treatment that was received in hospital. Indications on prescriptions are a big piece of the puzzle in a community setting. Without knowing what the antibiotic may be indicated for, it can be difficult for pharmacists to determine if the correct antibiotic is being used, and if so, if it's being dosed appropriately, especially for agents with a wide range of doses that are dependent on infection severity, such as amoxicillin, or agents that may be available with different release profiles, such as ciprofloxacin. By providing an indication on prescriptions, prescribers are also given an opportunity to truly consider if antibiotic therapy is warranted. Though this information can be determined through assessing the patient at the time that the prescriptions are dropped off to be filled, not all pharmacy workflow models accommodate this process, as assistants or technicians are typically delegated to this task. Also, by providing an indication, it allows pharmacists to tailor their counseling to be condition-specific as opposed to asking broad and open-ended investigative questions about the condition, which can lead to loss of confidence in the pharmacist when they're picking it up. So an opportunity then may be to have pharmacists do an assessment for each antibiotic prescription prior to the time of filling, so at the time of drop-off. At most pharmacies, the workflow model is that prescriptions are taken in, entered into the system, packaged, and then checked by the pharmacist. Then at the time of picking up the prescription, the pharmacist will counsel on the medication. This may be less efficient and time-consuming if the dose is determined to be wrong or ill-suited for the condition at this time. So say the dose is technically in the correct range, but it's not overtly wrong, but it's also not optimized for the condition that's being treated. By this point, the patient's probably less likely willing to wait for the appropriate changes to be made. And by doing assessment at prescription drop-off, there's also a better opportunity to intervene or counsel on the watch and wait technique that Joel talked about. And if the patient was given an antibiotic prescription at this time, they may choose to put it on file, and then if the appropriate course of action is to fill the antibiotic, then they can just call in. So another thing that's missing is patients' weights, and especially children's weights, that are lacking on many prescriptions in the outpatient setting. Antibiotics for children are dosed based on weight, and having it included as part of the prescription is essential to ensuring that the correct doses are being used. As well, not all parents know the weight of their child, which can result in some guesstimating on their behalf, and population-based estimates may not be correct and have the potential to lead to inappropriate doses being used. Lastly, the duration of treatment received in hospital is not commonly seen in outpatient prescriptions, especially those that are coming from the emergency department. In these cases, the pharmacist can be left wondering about the prescribed duration of treatment. For example, for a 5-day course of azithromycin, if the prescription's only written for 4 tablets, it kind of is odd and appears inappropriate unless it's revealed that the patient got 2 of the tablets in hospital. But if this information was just provided on the prescription, there's a lot less ambiguity for the pharmacist that's checking the prescription. So the next issue, that's a big one, is time constraints. So this impacts stewardship activities by reducing the amount of time that pharmacists have to check e-health for labs and susceptibility reports if they're available, and can lead to important counseling information being missed, especially in busy workplaces where you're being rushed or you're in a high-volume store. People don't want to wait that few minutes longer. In some stores, this can also tie into the feasibility of having a pharmacist assess all the antibiotic prescriptions that are coming in. And depending on the pharmacy, it may be viewed as disruptive to have the pharmacist working outside of the existing workflow model. Additionally, time to contact the prescriber is crucial for stewardship. When changes do need to be made for antibiotics, they should be done so in a timely manner to ensure that patients receive the appropriate therapy as soon as possible. This is often an issue in clinics where physicians may rotate or prescriptions coming from the emergency department, as well as on weekends, evenings, and holidays when the prescriber may not be available. Next, we have ease of accessibility. There's software inefficiencies that may be problematic. So for pharmacists, this can tie into taking off or removing, modifying or removing allergy information if it's inappropriately documented to begin with. That was one of the things that a couple pharmacists said was difficult to do with their systems. And for physicians, if they wanted to set up a pop-up prompt for the indication when they are prescribing antibiotics, and if their system doesn't allow them to do that, then that's kind of a barrier. Open communication pathways may also be an issue for pharmacists. And what we're talking about here is having a high-functioning professional relationship between prescribers and pharmacists. This relationship is a valuable asset for carrying out antimicrobial stewardship activities, as it impacts the pharmacist's ability to challenge prescriptions that may be inappropriate and is dependent on whether physicians are receptive to feedback and change. Without mutual trust and respect between healthcare providers, it's unlikely that patients will receive the best possible care. This also ties into time constraints. Having a good relationship can really reduce the time to contact the prescriber. There are various working relationships with prescribers in the community setting, with some of the physicians refusing to take phone calls and only accepting fax clarifications, while others where pharmacists may have direct access to clinic lines, to clinic phone lines, and cell phones outside of regular office hours, which can facilitate faster responses from the prescriber, which contributes to better patient outcomes when the changes that need to be made are done so in a timely manner. Also talking about having a trusting prescriber-pharmacist relationship, it's important that you and your patient have a trusting relationship, and that was mentioned as one of the barriers when you're trying to talk to a patient and explain to them and educate them why an antibiotic may not be appropriate. If they don't trust you, then they're not going to go for it. Lastly, a barrier to overcome is ensuring that all community pharmacists have a good understanding and working knowledge of what antimicrobial stewardship is and what it looks like in the community setting. So of the pharmacists that we spoke with in our interviews, there were major differences in their understanding of what stewardship was and what it looked like in each of their own practices. Those that had previously worked in a hospital setting were much more familiar with the concepts of stewardship, while those that did not or didn't have a hospital background tended to have a limited or superficial understanding. This disparity must be addressed and can be bridged through education opportunities through continuing education credits or expanded outreach from the Antimicrobial Stewardship Program of the Health Region. But in order to address this disparity, it's critical that we identify where the gaps are in knowledge and that we ensure that all community practitioners are on the same page. So all healthcare providers have an important role to play in minimizing antibiotic resistance through stewardship, and all community pharmacists need to be aware of their roles and be more involved.
So our last point really has to do with how we measure success. According to our working definition, stewardship exists to optimize antimicrobial use and improve patient outcomes. Therefore, several measures can be used. This may include reduction in adverse effects related to antimicrobials or shifting susceptibility patterns and reducing resistance in organisms seen in practice. Much of the data we have relates to hospital use of antibiotics. This includes length of stay in hospital, antibiotic use rates per institution, readmission rates, and mortality rates. As we briefly mentioned at the beginning of our presentation, we searched primary literature databases for information pertaining to stewardship in the community. We found that there is very little data specifically relating to community antimicrobial stewardship, although we can infer that some success in hospital can be related to efforts made in the community. Other measures we can use specifically to measure community success may include rate of physician visits for antimicrobials, rate or ER visits for antimicrobials, or total use of specific antimicrobial agents used in the community setting. It is also important to note that it may be difficult to retrieve some of this data if we were to seek it out, as provincial databases for drug use have strict confidentiality laws protecting the information collected, even if this information has been de-identified.
So that kind of concludes our presentation. We wanted to say a special thank you to these pharmacists that took time out of their busy days on such short notice and participated in our interviews on antimicrobial stewardship in the community. We couldn't have made this presentation without them. So we thank you again.
So we'll open it up to questions now, but before we do, we just also wanted to mention that if any community pharmacists are watching and want to become more involved or provide us with some input or feedback regarding outreach opportunities and antimicrobial stewardship in the community, feel free to contact the Antimicrobial Stewardship Program through email. We have it on the slide here.
Thanks.
So great job, guys. I think to start, we'll open up questions to our remote sites. So if we have anyone on telehealth or tuning in via WebEx, do we have any questions, Bob? Or
unmute their mic.
yeah. Oh. So for remote sites, if you can unmute your mic if you want to ask a question, just do so now, and we'll see what we can do for you. Any questions from
Nice.
remote sites? How about?
It was
No,
so.
we're good here. Thanks. Thanks for your presentation.
Thank you.
Thanks for participating. Oh, cool.
All right,
From
Rachel.
with- We have some pharmacists in the WHA in the audience as well, and they're wondering if you can describe what the stewardship program at Regina Hospital is like.
Well, it's kind of a mix. There's definitely a clinical portion, so we go work with Casey, and if people want to consult us, we kind of do
Like we've paired up with the ID physician that's on call here, and then if there are any consults to ID, then we kind of are with them working as a team to determine what antimicrobial therapy they should be on. And then there's also the aspect with like the research portion of it, where they do prescriber feedback and audits for those prescribers in the community to give them feedback on how they're doing with prescribing. And then we have a clinical appropriateness analyst that kind of looks at whether or not things are appropriate.
And since it's such a new program still, they're doing a lot of outreach in the community just to get themselves out there so everyone has an idea of what we do. So there's school presentations and workplace presentations, and we've attended a couple conferences. And
A lot of it has been just showing people like what it is, because a lot of people still don't really know, right? So yeah. It's a great rotation, Kelly. Send your students here.
Yeah. Do you guys get any feedback from any patients?
No. Like,
Do you mean community patients or hospital patients?
Or inpatients?
Sorry, say that again?
Yeah, primarily community pharmacy patients, but maybe even hospital inpatients.
13 seconds.
Yeah, we haven't had any specific feedback from those patients, but I know, going around in sort of a team-based approach in the hospital, I know patients really do appreciate having a number of people looking at their care and trying to do their best to optimize their care. But I would be very interested in hearing more from the community side about what patients, how patients feel their pharmacists could help them in optimizing antibiotic and antimicrobial use.
Great. Thanks so much, you guys. It was great to be able to log in and hear your presentation. Good job.
Thank
Thanks,
you.
Kelly.
And any other remote, either WebEx or telehealth questions? Do you have anything yet, Bob? Nothing yet? How about anyone in the room here or anyone over at the Regina General this morning?
Michelle's.
Actually, yeah, it creates user-friendly antibiotic.
Sorry, could you repeat that?
Yeah, and I think just if your questions are done, just please mute your mic.
Something about antibiogram?
Corey, I got a question for Mooseman. Great presentation, you guys. Does any province, have they implemented mandatory indications on antibiotic prescriptions? Because when I think of everything that's going on, I know there was a project in Regina with UTIs where they required indication for the antibiotic, but to me, if it was mandatory at a prescriptive level, that may help.
Not specific, like not that we are aware of in anywhere in Canada. I mean, to be honest, we only know about Saskatchewan and Manitoba. We found, like in Manitoba, nurse practitioners and physician's assistants have to provide indications for all prescriptions, so that really helps things. But like, so yeah.
I definitely think having a mandatory indication on prescriptions would help. I think a lot of physicians would only do it if it was mandatory.
Yeah. There was a interesting little study that the Antimicrobial Stewardship program that found that there was 94% for your nurse practitioner.
Right, and that's one thing we've been trying to work on with the family physician clinics that we've engaged with in Regina and rural Saskatchewan is, encouraging them to include an indication on their prescriptions. And there are some of the practitioners who are there that do a great job with it, and other ones that were just unaware that they were even able to do it on their EMR. So it's a bit of a process, just educating the physicians and nurse practitioners on how to do it as well. So it's a work in progress.
Just to define your question a little bit more, so across Canada, it's still a recommendation that any order, whether it's a physician order in hospital or in community, should have an indication with it. And I think that's where things are. So it's not a mandatory thing. And I think, like Casey was talking about, how we've been trying to collect data and talk to physicians about. I don't know if making it mandatory right off the hop would be the best approach. I think just looking at the uptake and the agreeance of the people that we engage with around the necessity for the orders with indication, and then trying to make progress there. And then in the future, as we move forward, I know in the RQ, it's actually going to become a mandatory field in the CPOM. So our computerized physician order management system will have an automatic pop-up box that if an antimicrobial is ordered, it'll say indication, and then, but within our rural communities and some of the smaller hospitals, until that CPOM is in place or some sort of computerized management system.
It's kind of just a recommendation at this time.
And we're definitely saying it's a strong recommendation and hoping to have success there because, again, it just, all the connectivity from the delivery, the understanding, the education, from the nurse practitioner, from the pharmacist to the patient, just everybody's included in that when that indication is there. So I hope that answers your question.
Great. Thanks, Bob and Casey and crew.
Thanks for the question. And any last questions? We've got a couple of minutes left here. All right, well, I just want to thank everyone for tuning in. We're going to also have this presentation available up on our website soon, I hope, so anyone from the community or who has missed the presentation is able to tune in again. And thanks again, everyone. And one last big hand for Joel and Victoria putting this presentation together. You did a fantastic job.